Good evening and Salam Alaikum. First of all, I'd like to thank Professor Dr. Abdul Qadir Akanda for inviting me and giving me this opportunity to present my talk in front of so many eminent cardiologists of Bangladesh. And I'd like to, before starting, I'd like to just give a short introduction of mine. That I studied in Bangladesh in Mymensingh Medical College. So সেজন্য আমি ভালো করে বাংলা বলতে পারি, and I love Bangladesh. I always like coming to Bangladesh because I have so many friends here. I go to their homes, have different varieties of mats, especially Ilish mats. I like it very much. So my topic is rapid evidence-based sequencing of foundational drugs for heart failure. Heart failure is a public health emergency, and estimated 64 million people living with heart failure worldwide. And heart failure is the end stage of many conditions we know: hypertension, diabetes, valvular heart disease, coronary heart disease, obstructive sleep apnea, and obesity. And we also know that 50% of patients with heart failure will die within 5 years. And now we have some therapies can dramatically alter the natural history of the disease, which is otherwise universally fatal. Despite the incredible advances in heart failure with reduced ejection fraction treatment, utilization rates, guideline-directed medical therapy is poor. Like AC inhibitor and ARB is just 60 to 80%, ARNI 10%, beta blocker 60 to 80%, MRA 30 to 60%, and there isn't much data regarding to what percent SGLT inhibitor is being used. And I wanted to find out to what extent like we are using, especially in Bangladesh and Nepal, and I couldn't find any data. So I decided to do my own little study in a medical college where I work, which is Kathmandu Medical College, and we searched for discharge summaries of from June to July 2023, and we categorized two groups with HFpEF of more than 50 and HFrEF of less than 40, and we omitted the in-between ejection fractions just to avoid any ambiguity. And it was a retrospective cross-sectional observational study, and we found out that most of the patients having heart failure were more than 50 years of age. Sex ratio was similar, male and female, and the comorbidities were hypertension, diabetes, coronary heart disease, valvular heart disease, and chronic kidney disease. And interestingly, this is what we found out. Though this is not a great study, there are very few patients. We had 10 patients in heart failure with preserved ejection fraction and 40 in HFrEF. And interestingly, we found out that there are only 16% receiving digoxin, 100% were receiving loop diuretics in HFrEF, and around 90 in HFpEF. And then AC inhibitor and beta blockers were more or less around 50% in both category. And MRA, interestingly, was quite high, above 80% in both group. And we don't have ARNI in our country, so obviously it's 0%. And then SGLT2, interestingly, in HFpEF we found around 40%, and in HFrEF 33%. And there was a mortality of 25% in HFrEF, 0 in the HFpEF in the duration that we followed up. Though this is not a great study, I've already told you, that it does give some picture, like how we are using the 4 foundational drugs. Now, we all know that ACC-AHA categorize HFrEF, HFpEF, and another one, heart failure in borderline ejection fraction. And one more category has come up, that is heart failure with improved ejection fraction, which was less than 40% in the beginning, and with treatment has improved to more than 10 points. However, according to this study by Shah et al. Published in the Journal of American College of Cardiology in 2017, heart failure with preserved, borderline, and reduced ejection fraction 5-year outcome, there does not appear to be any major differences in mortality, prognosis between EF groups. I always thought that HFpEF had a better prognosis. And, but interestingly, this was proved wrong. According to this study, heart failure is associated with markedly lower median survival, poor long-term prognosis, and increased risk of cardiovascular and heart failure admission, regardless of the EF classification. And this study analyzed data from the US Centers for Medicare and Medicaid Services, examined data from almost 40,000 patients from 254 hospitals, and they categorized FPF, and they had around 18,000 of FPF, borderline of 3,000, and 18,000 of reduced ejection fraction. And they came up with this very interesting graph. The median survival of patients hospitalized with heart failure compared to the general population was similar by EF group, whether it was according to the age group, whether it was HFrEF, the yellow bar, the borderline, the green, the brown bar, or the HFrEF, the red bar. There was hardly much difference between survival, hardly much difference between the 5-year survival, and it was markedly reduced compared to the general population. So heart failure is a clinical syndrome. We don't need EF to diagnose heart failure. What we must have is the dyspnea, fluid retention, and there should be something wrong with the heart. So according to the 2022 guideline, quad therapy has been class 1A recommendation for HFrEF, and I will not be going into details of that. And then very interestingly, the clinical benefits of all these medications, all these 4 medications, all the 4 pillars of heart failure medications are apparent within 30 days of initiation. So this is important. Right from it, the clinical benefit is apparent within 30 days of initiation. And for the mid-range ejection fraction, SGLT2 inhibitor is the only class 2A recommended drug at the moment, and the other drugs are 2B recommendation. And for the HFpEF with ejection fraction of 50%, medications with a class 1 recommendation for HFpEF, beside loop diuretics, there is none. So what do? We just treat the comorbidities. If the patient is obese, lose weight. If the patient has AF, try to get them into sinus rhythm. If there is sleep apnea, we do sleep study and CPAP mask. But the biggest news from the guideline from the last year was SGLT2 inhibitor, which is a 2A recommendation, which was based on the Emperor Preserve trial. And here you can see that compared to placebo, the curve starts separating right from the beginning of the treatment. And the effects are consistent whether the patient has diabetes or non-diabetes. But one thing that we need to keep in mind is that this is not a mortality benefiting drug in case of HFpEF. This effect was mainly related to the reduction in heart failure hospitalization. And we still do not have any medications that can reduce the mortality in case of HFpEF. ARNI, AC inhibitor, ARB, beta blockers, PD5 inhibitors, nitrates, all have studied in HFpEF trials, but none of them came up with any significant results. So if you look at the mortality curve, there's hardly any difference between the placebo and the drug they used, empagliflozin. So when you are talking about the HFpEF, we need to keep in mind that though this has been recommended by AHA and ACC, this is basically meant for heart failure hospitalization, not for mortality benefit. So for the preserved ejection fraction, SGLT2 inhibitor is the only 2A recommendation to decrease the hospitalization. And one more category that that is there is that improved left ejection fraction, which was less than 40 in the beginning and which has improved to more than 10 points. In this category, what we need to understand is that we are not curing heart failure. Heart failure is a chronic, incurable, lifelong disease. So we are only putting it into remission by medical therapy. So it is recommended not to stop the medications. So even if the patient has improved, and even if the patient has reached normal EF, the medicine is supposed to be continued lifelong. Now coming to the practical consideration for the prescribing guideline-directed medical therapy, I have taken this proposed rapid upgrading of the 4 pillars of drug from this article. And what we are doing, our conventional approach, is basically based on historically driven sequence of the last 40 years. That is, we start with AC inhibitor or ARB, followed by beta blocker, then add mineralocorticoid receptor antagonist, followed by ARNI and SGLT2 inhibitors. And this typically takes more than 6 months. We titrate dose of each drug class to target dose used in large-scale trials before initiating next recommended dose drug class. So what this assumes is that most effective and well-tolerated treatments were developed first. Historical precedent is not a strong rationale for making therapeutic recommendations. Digitalis has been used for more than 200 years, but it is no longer a cornerstone of therapy. And another limitation is that it assumes that foundational drugs is effective only when titrated to target dose. And it may take more than 6 months to prescribe all the recommended treatments if we try to reach the target dose. And delay of 6 months may not be acceptable because we now know that we have enough data to show that each drug has been shown to reduce morbidity or mortality within 30 days of initiating the treatment. So rapid sequencing is now preferred, and all 4 drugs are proposed to be started either rapidly in sequence or simultaneously, as long as the patient is hemodynamically stable. And it is initiated at the lowest dose and up titrated every 1 to 2 weeks as tolerated. And what we need to monitor is blood pressure, electrolytes, renal function throughout the up titration. And ideally within 6 to 8 weeks, a HFrEF patient would be receiving target doses as tolerated. So rapid sequencing has been based on 4 principles. The first is all 4 drugs reduce morbidity, mortality within 30 days, so start all of them as soon as possible, within 2 to 4 weeks. Number 2, efficacy of each drug is independent of the other drug. So priority can be determined by relative efficacy, safety, and ease of use. Number 3, low starting dose of each drug has substantial benefit, so starting with low doses of all 4 drugs should take precedence over up titration to target doses. For SGLT2 inhibitor, the starting dose is identical to the target dose. And number 4, proper sequencing of drug classes can improve safety and tolerability. For example, neprilysin inhibition can reduce the risk of renal insufficiency produced by an AC inhibitor ARB, and both neprilysin inhibitors and SGLT2 inhibitors can minimize the risk of hyperkalemia with the use of MRAs. So the three-step approach has been proposed for ambulatory patients. After diuretics has achieved clinical euvolemia, that is absence of rales or ascites and presence of no more than minimal peripheral edema, in step 1, we may add beta blocker and SGLT2 inhibitor simultaneously, followed in a week or 2 with ARNI, and then followed by MRA. Steps 2 and 3 can be reordered or compressed depending on patient's circumstances. So the rationality of these 3 steps are: step 1, simultaneous initiation of treatment with beta blocker and SGLT2 is that beta blockers is the single most effective drug class for HFrEF, particularly with respect to the reduction of certain cardiac death. And SGLT2 has a striking effect on reduction of risk of hospitalization for heart failure. And their early diuretic action may mitigate the short-term risk of worsening of heart failure that may occur after a beta blocker is started. And in step 2, addition of ARNI within 1 to 2 weeks of step 1. If the patient's systolic blood pressure is less than 100, it may be prudent to first evaluate tolerance in relation to hypotension with an ARB before switching to an ARNI. Any hypotensive effects commonly resolve with repeated dosing or with adjustment of dose of concurrently administered diuretics. And step 3, addition of an MRA within 1 to 2 weeks of step 2 if potassium is normal and renal function is not severely impaired. The favorable effects of neprilysin inhibitors and SGLT2 inhibitors to improve renal function and potassium homeostasis may increase the tolerability of MRAs. So MRA may be step 2 in patient with troublesome hypotension. So coming to conclusion, there is robust evidence behind the life-saving pharmacotherapies of chronic heart failure with reduced ejection fraction. Optimal utilization of such medications is lacking. Historically, the mainstays of HFrEF therapy was started individually and titrated slowly. New evidence suggests that simultaneous initiation and rapid titration of comprehensive disease-modifying medical therapy, namely ARNI, SGLT2 inhibitor, beta blocker, and MRA, is safe, effective, and derives the maximum benefit for the patient. Thank you.
Thank you, Dr. Sanjay Kumar Shrestha, for his nice presentation.